Hi there, I'm Jennifer Rickard. I'm a global surgeon here at University of Minnesota, and I'd like to talk with you all today about my path to becoming a global surgeon and what it's like being a global surgeon. To begin with, I never really traveled a lot in my younger days, but I was certainly interested in things like going to Africa. In my undergrad studies, I finally broke down and decided to try a study abroad program. And since I'd always been interested in Africa, I thought I'd go there. The options available to me at that time were pretty limited, so I decided to go to Kenya. And through that program, it was actually the Minnesota Studies in International Development that I went with. And this program was a particular program focused not just on study abroad, but also international development. And so it was a great opportunity for me to go spend a year living in Kenya and taking courses there. But in addition to that, this program put people on specific internship programs. So based on your particular interest or field, they would match you with a specific program or group. So people who were interested in wildlife management might work with the group working with colobus monkeys. I showed interest in medicine and research. So I had the opportunity to work at the Kilifi District Hospital, which is a district hospital on the coast of Kenya, where the Wellcome Trust does a lot of work with research, medical research. They do a lot of sustainability programs and working with the community as well as in the district hospital. So it was a wonderful first experience to really see how global health in a low-income country works. From there, I proceeded to go to medical school, and I started to look into different options of continuing global health in my career. There weren't a lot of opportunities that I was familiar with, so I started just reaching out to people, emailing people, trying to find other opportunities, particularly between my first and second year of medical school, when you have a few months free to explore and travel and try different things. I was able to connect with an Army officer working in Kenya again at the time, and he offered me some opportunity to research on, I believe it was diarrheal disease and stool sampling at that time. And I wasn't particularly interested in that, but again, I thought I'd keep my options open. It turned out about 2 days before going on this trip, there was an outbreak of viral hemorrhagic fever in the area that he was working. And so when I got there, he said, well, you can come and do stool research, or you can do this outbreak investigation. And I said, you know what, I'm far more interested in doing an outbreak investigation than stool research. And so I had this wonderful opportunity to, again, see how an outbreak investigation works in these areas. Throughout all this time, I'd assumed that I would go into something like infectious disease, internal medicine, pediatrics, because these are the fields that were generally amenable to global health work. However, when I started getting into my clinical years in medical school, I realized that those fields didn't interest me quite so much. I didn't find passion for them as I'd expected to find. And I'd never really considered surgery as a career option at all. It just didn't seem to fit with my personality or what I'd expected. However, when I finally did my surgery rotation, I was surprised to find that this was actually something that I was very interested in, and I was very passionate about surgery. So surprisingly enough, I went in and did my surgery residency. This was a bit of a challenge for me because at the time there wasn't really a lot of global surgery work being done. In fact, the fields of global health and surgery were kind of two different ideas, didn't really overlap. There's not a lot of opportunities in residency to do global surgery work. I was able to find some opportunities to do a mission trip through our university down in the Dominican a couple times during residency. But again, the field of global surgery hadn't really emerged at that point. However, I just kind of stuck with it, waiting to see what would happen and evolve. And in my later years of residency, the Paul Farmer Global Surgery Fellowship evolved, and there started to be an inkling of interest in global surgery at that time. So by the time I was finishing up with residency, I had to decide what it was that I was going to do when I finished my training. I knew, again, I wanted to integrate global health into my work. I just didn't know exactly how that would be. So I decided to follow up on the Global Surgery Fellowship Program through Paul Farmer. I contacted them, I applied for the program, and they reached out to me and said, here are the kind of things that we have going on. We have a program in Haiti. They have a very strong Partners in Health program with a hospital in Mirabelais. Or there's this new program that is getting started up in Rwanda called the Rwanda Human Resources for Health Program. And they told me a little bit about that program, and in the end, that's where I elected to go. So after residency, through this Global Surgery Fellowship, I did the Rwanda HRH Program. So what the Rwanda HRH Program is, it's essentially a program designed to scale up the healthcare workforce in Rwanda. It is designed to be a sustainable program where over a period of years, we train up enough healthcare workers that they can continue to train people themselves. So the program brings over 100 or more people who are doctors, nurses, midwives, health managers, all different sectors of the healthcare workforce to teach and train Rwandans how to do this. They already have training in these programs there, but it helps increase the amount of trainees that they can produce. It's also designed to help improve the quality of training there in Rwanda. And it provides specialists from all different fields, medicine, pediatrics, surgery, dentistry, to cover the entire spectrum of healthcare. And the program was designed to initially be there for 7 years, with the idea that after 7 years, you've trained up enough Rwandans that they continue the program themselves. So I went over to Rwanda in the first year of the program with about 100 other doctors, nurses, midwives from all different specialties, and we started this program, twinning and partnering with Rwandans to help increase the health force capacity there. Throughout this time, I also knew to kind of augment my educational training, I was interested in getting a master's in public health, just because this provides more education that seems beneficial continuing a career in global health. Timing-wise, it was something difficult to work with. Most Masters in Public Health programs go over a 1 to 2 year period. However, at the Harvard School of Public Health, they have a particular Masters in Public Health program that is designed for professionals who have advanced degrees, where you can do your Masters in Public Health over a couple different summers. So over a period of 2.5 years, I got my Masters in Public Health through summer classes at Harvard. I worked in Rwanda for a couple years doing this, getting my Masters in Public Health, working with the Rwanda HRH program. After I'd done this for about 2 years, I thought it was time to come back to the US and really start my career program. Here it was kind of the question of, what do I do next? Can I continue to integrate global surgery into my career? And that was something I didn't really know. I knew a few examples of people who had some global surgery integrated into their career. Oftentimes people use vacation work to do it, or they might have 1 or 2 months, maybe 3 months of protected time. Often they take salary cuts to make it work. But you still need a department that's supportive of the idea. So I reached out to a few different places, trying to see if I could find opportunities to do this. I kept it a pretty broad focus. Essentially, I was looking for a job, but I wanted to see if anybody actually had interest in doing or starting global surgery work. And that's how I ended up at University of Minnesota. They were one of the places that I reached out to, and they showed a true interest in integrating global surgery work into the program. Throughout all this time, I then elected to also get a fellowship in surgical critical care. Not only does it strengthen and augment my work that I do here in the US, but it's also been very useful for my work in Rwanda. While there's not a lot of resources in Rwanda and I can't do all the high-tech things that you can do here in the US, there are still a lot of critically ill patients in Rwanda, and so having that background and training has been very important, both for patient care, but also expanding the teaching and training of junior residents and junior faculty there. So a little bit about my current position. Right now I work 6 months in the US and 6 months in Rwanda. My work in Rwanda, I'm employed by the University of Minnesota, but most of my clinical time is spent at a level 1 trauma center here in the Twin Cities area. At that center, I do trauma work, I do acute care surgery or emergency general surgery, and I work in the ICU. For the past 3 years, those 6 months that I've spent in Minnesota have all been in the winter, so it's been quite a challenge coming here and being here in the winter. It has been nice to experience snow and cold weather after I'd lived in perpetual summer for about 3 years. However, I expect that will change in the coming years, where I'm hoping to be here more in the summer when trauma tends to be a little bit busier, and they're in Rwanda during the winter. My time in Rwanda, as I said, 6 months there. I live and work in Kigali, so I live in pretty normal living conditions. It's an apartment. I don't live in a hut. You can do pretty much anything that you want in Kigali. It's not roughing it too bad. There's movie theaters, there's all sorts of fine dining establishments. So you're not really living in a hovel or a dirt home or anything like that that people sometimes imagine living and working in Africa. It's pretty modern there. The hospital itself, it's a tertiary level hospital. So it sees a large burden of patients. It's about a 565-bed hospital. It has 6 main operating rooms. It's got a 7-bed ICU. We have a CT scanner. There's an MRI at a different hospital in the city that we can use. So there's many resources that we do have. Most of my work centers on teaching students and residents, and this is done very similarly to how we do it in the US. I'll go on rounds and I'll see patients with the students and residents. I'll help the students and residents make plans. Patients who need to go to the OR, we go to the OR together. Wherever possible, the residents will do the case and I'll help coach them through it on cases that they are pretty simple, that they have a lot of experience with. They may do the case themselves. Obviously, the more complex cases, I'll take them through it. So it's very similar to what we might do at home here. I also spend time in the ICU, and that really just depends on how my schedule is looking. The ICU there is run by the anesthesiologist, but a large burden of the patients in the ICU are surgical patients. So I will see them either on my clinical rounds as a surgeon, or sometimes I will spend time teaching and training in the ICU. Also, because I have this critical care training, I do the critical care teaching for surgery residents. Throughout all the time there, also worked on developing a research program. And this has been for a variety of different reasons. A lot of it is my personal interest in the subjects and topics that I see there. You see things that there's not a lot of data or research on, so you want to collect the data and share it with others to help either inform my decision making or my colleagues' decision making. Also just increase the amount of research on the topic so that other people in other settings in sub-Saharan Africa might kind of collaborate and learn more about it. It's also, I think, beneficial to the trainees, students, residents, and junior faculty that I work with. They obviously want to develop and hone their research skills, and so it's nice to collaborate with other people on research projects, and so we can all work together and learn a little bit more about things. Given the work that I do, my research topics generally cover the clinical topics that I'm interested in. So things like acute care surgery. I see a fair number of infections, so interested in infections and the antimicrobial resistance patterns that we see, and starting to look at some of the nutrition factors that impact surgical outcomes. So just based on what I see and the challenges that we're seeing, those are the type of research projects that I'm currently working on. And then other things that you naturally work on as you're living and working in Africa, especially for these long, prolonged periods of time, is things like administration and system building. We kind of take this for granted, all the administrative work that goes into both a clinical department as well as a educational department, but there's a lot of administration that needs to be done, whether it's helping to organize and design exams, organize and design a curriculum, how patients flow through the hospital. These are all administrative things that you really need somebody on the ground who's invested in the program to kind of help and collaborate with. And of course, everything that I do is done in conjunction with my Rwandan colleagues. Nothing is ever done just by me individually. A little bit about what I see and do comparing Minnesota and Rwanda. I would say in general things are pretty much the same, but they're kind of different. It's really hard to describe. A lot of the cases you see are the same. Again, I do similar work. It's trauma and acute care surgery in both settings. Trauma patients are trauma patients. The difference is going to be trauma patients in the US, they come within minutes to hours of their injury. Trauma patients in Rwanda are generally hours to days, and it kind of depends. Every once in a while you see somebody who might have been injured just a few miles from the hospital, and so you might see them within a few minutes, but most commonly it's hours to days later that you see these trauma injuries. So you can imagine the types of trauma that you see and manage are a little bit different. Same thing with the acute care surgery conditions. We see things like appendicitis, peptic ulcer disease, bowel obstruction. It's the same sort of cases. It's just a little bit slightly more delayed. Oftentimes your patients in Minnesota, they'll come in with maybe 1 to 2 days of symptoms. Whereas in Rwanda, it's much more likely that they've had symptoms for 4 or 5 days before they see you. So if you get all the way to the hospital in Rwanda, you almost always need a surgery for something. Whereas in Minnesota, there's a fair number of patients that I'll treat and manage medically, and they may not need to actually have a surgery. Every once in a while, I do see conditions that are unique to tropical countries, low-income countries, things like worms. I don't ever see worms or ascaris obstructions in the US, but those are things that every once in a while you'll encounter. Things like typhoid perforation. I do see that in Rwanda fairly commonly, but of course I don't see that in Minnesota. Sigmoid volvulus is actually very common in Rwanda. Again, you can see sigmoid volvulus in the US. It's a little bit different presentation. There in the US, it's mostly elderly people, whereas in Rwanda, you see it in much younger population. Some of the other things that are different, language is a little bit different. Obviously in the US, primarily everything is done in English. If somebody comes in who speaks a different language, I get an interpreter. I'll often have interpreters there at the bedside all day long who are available whenever I need them. In Rwanda, the national language is Kinyarwanda. Once you get into your educational system, it's a fair number of people do speak English. A few years ago, French was the language of education, so some of the older generations speak more French than English, but the younger generation speaks English fairly well. All of our teaching and training is done in English, so I get by my regular day just talking with everybody how I normally would. I think the big difference is I don't talk with the patients in Rwanda the same as I do in the US. Because most of my patients speak Kinyarwanda and may not have as much education, so they don't speak a lot of English. I don't have the opportunity to speak with my patients. And I notice that a lot when I come back to the US and I'm able to talk and really connect with patients, and so that's a big difference. I think it's also a difference in teaching and training how to communicate with patients. I don't get that opportunity to teach my junior residents and medical students how to take a history and physical, or how to convey bad news to a family, or have goals of care discussions. Because I can't model that behavior for them, I can just tell them what it is that I would say. And I don't get that feedback from them, what they're actually conveying to the patients or families. Other things that are obviously different are resources. Again, I work in a tertiary hospital. We have a lot of resources. We have laparoscopy, we have the ICU, we have CT scanners and MRIs, we have pathology. So we actually do have a lot of resources, especially compared to other hospitals in sub-Saharan Africa. One thing that's been raised is it's not a strict material resource limitation, but oftentimes it's the variability in those resources. All right, over the times that I've been there, I've run out of just about everything. Now, like I said, all these resources are available, but over a period of 7 years, that CT scanner is going to go down, at least for some period of time. And so you need to learn how to manage patients, not just with a CT scanner, but how you're going to take care of them if the CT scanner isn't available. It's also that idea is that's one CT scanner for almost 6 million people. And so it doesn't happen as quickly or rapidly as you might otherwise expect it in the US. If I want a CT scan in the US, I know I'm going to get that CT scan the same day, and oftentimes within a period of a couple of hours. However, in Rwanda, if I want a CT scan, I kind of have to judge, if I get the CT scan in 3 days from now, when the patient will actually get it scheduled, is it still going to be valuable to me? Oftentimes for surgery patients, 3 days later, I've already decided if they need that operation or not. And so I may not want to wait for a CT scan, and I'll just go based on my clinical judgment and how the patient evolves over that time period. So there's a lot more reliance on clinical skills. There's a lot of different things that we do that are kind of innovative and working with systems to try and communicate with people. Everything that we do is based on paper charts, though they are introducing electronic health records slowly and over time. So our labs are on the computer, but our notes are all written in a paper file. They often use things like WhatsApp to communicate with team members so that everybody knows and has an update on what's going on. And you'll see that we leave little notes to each other. So when you have a dressing that needs to be changed, we write a note saying, reminding people to take a picture of the wound, because that wound gets changed once a day. You can't take it down a second time later in the day for another team member to see it. We just don't have the dressing supplies to do it multiple times a day. So people get one dressing change. And so if you want everybody on the team to see it, you kind of have to take a picture and share it so that everybody knows what's going on. So these are all the reasons why I'm interested and passionate about the field of global surgery. I think it brings me perspectives from both my worlds. Working in Rwanda helps me become a better physician in Minnesota, and again, my work in Minnesota helps augment and contribute to my work in Rwanda. I really feel like I get the best of both worlds, and overall it helps remind me of all the reasons why I wanted to be a doctor in the first place. Thank you very much.